Lewis, who will be presenting on adherence to lifestyle intervention in adults with obesity. Thanks very much, Emma.
Hi, everyone. Thanks, Nick, for the intro. So I'm Emily. I'm an APD, an AEP, and a PhD candidate with the Uni of Canberra. My thesis is due back from the examiners very shortly, so I'm on the finish line, which is exciting. I've also been working with the Obesity Management Service for the past 5-6 years or so since their inception. I've worked there as both the EP and now currently the dietitian. My presentation today is on adherence to lifestyle intervention for adults with obesity, which is just one part of the PhD that I've been looking into. So to get us started, I think it's really important to just very briefly touch on the prevalence of obesity. Over 650 million adults worldwide are classified as obese, which is around 14% of the world's adult population. In Australia, the prevalence of obesity increased from 19% in 1995 to 28% in 2015. So that amounts to around 1 in every 4 Australians being classified as obese. So it's a hugely prevalent chronic disease here and around the world. Now, there's a wealth of research looking into obesity management from varying dietary regimes, exercise prescriptions, psychological interventions, pharmacotherapy regimes, bariatric surgery procedures. There's research about all of it, but we just don't seem to be getting on top of the rapidly rising prevalence of obesity. Now, one of the key challenges in obesity management lies in the poor rates of adherence to lifestyle intervention for adults with obesity. Only 5% of Australian adults eat their recommended serves of fruit and veggies. Only half of us are meeting the physical activity guidelines, and reported attrition rates from weight loss and lifestyle intervention programs can be really, really high. So we know that poor adherence to treatment is one of the major factors limiting weight loss maintenance, and health behaviour change for adults with obesity. It results in poorer healthcare outcomes, reduced healthcare costs, underutilised or even wasted healthcare resources, and reduced patient quality of life. Hence, a better understanding of the mechanisms of adherence is obviously vital to the development of successful obesity management programs. So that is where my research has come in over the last couple of years, looking at the concept of adherence. My primary aim of my research to date has been to explore the issue of adherence in obesity management. I've been looking at the key barriers to behaviour change for adults with obesity. What are the main predictors of adherence and attrition? Are there treatment strategies that we can use to improve adherence? And how can obesity management services implement these strategies to be able to improve their model of care? So today I'm just discussing one part of the research, which is an RCT I did with the Obesity Management Service. We conducted an 8-month randomised controlled crossover trial exploring the use of telephone and text message support in obesity management. We were interested to see whether the addition of telephone and text support to an obesity management service or to a community-based obesity service would improve lifestyle intervention adherence and clinical outcomes when compared to standard care. My prior research had found that the use of behavioural treatment strategies, such as motivational interviewing, problem solving, goal setting, self-monitoring, all those classic behavioural strategies that we use, really was effective in improving adherence for adults with obesity. And we know that really regular and consistent patient-provider contact is really important for adults with obesity. But the million-dollar question then becomes is how can we offer this really regular and frequent patient-provider contact and the level of behavioural treatment that we know that adults with obesity need in publicly funded community services that are struggling under really, really high demand. Often the intensive approach that we see within academic-based lifestyle intervention programs is effective, but it's not sustainable within a community environment. It's often considered far too burdensome and expensive to be sustainable in a publicly funded community environment. So we need to look for innovative ways to be able to implement some of those strategies within these community environments, which is where the idea of telephone and text message support comes in. Now, we know that technology has proven to be a really effective tool in a variety of health domains, but all prior research in obesity management had looked at the use of technology in comparison to standard care, or in comparison to a no-contact or a self-directed control, or as used as a maintenance tool after completion of a standard care or a lifestyle program. But no one to date had looked at the use of telephone and text message support as an adjunctive tool to be used in conjunction with a program. So that's what I did. I was using the use of telephone and text while they were already receiving the standard care. It was used as an adjunctive tool, which hadn't been done before. So participants were randomly assigned to receive 4 months of telephone and text message support in addition to the standard obesity management service care or standard care alone. And after 4 months, they then crossed over to the alternative sequence for 4 additional months. Within the intervention, we provided monthly telephone calls over that intervention period. The telephone calls were really used to create goals for the participants. We used a lot of the motivational interviewing and the behavioural treatment strategies within those calls. And then from there, from the telephone calls, I was able to individualise and tailor the text messages that I'd send throughout the month. So participants got 3 text messages a week, and those texts were really aimed to remind participants of the goals that they'd set, but also just offer a sense of support and accountability and motivation and guidance to give them that extra sort of care and contact over that time period. The control period, just for those who aren't as familiar with the obesity management service, so we're a branch of the chronic disease management unit. We are a multi-D team. We have doctors, nurses, dietitians, exercise physiologists, psychologists within the team. Treatment is really individualised, but we offer group and individual support. So we've got group psychology programs, we've got group exercise classes, group allied health education groups, individual face-to-face appointments with all of the different allied health staff and regular medical consults. And then we also offer more intensive therapies where necessary, such as very low energy diets, pharmacotherapy and bariatric surgery. So that's what the control sequence or the standard care sequence entailed. Okay, so this is some of my inclusion criteria. Participants had to have class 3 obesity or a BMI over 40. They had to have an ability to self-manage, access to a mobile phone, and ability to be able to use that mobile phone effectively, and be willing and able to receive the text messages and the phone call over the time period. We looked at dietary adherence, physical activity adherence, all of your anthropometrical measures, self-efficacy, and treatment self-regulation. The intervention was heavily grounded in behavioural theory, which was where I'd sort of directed my prior research. So as I've been saying, we used goal setting and problem solving and all of those treatment strategies within the telephone calls and the text messages. This is just a couple of examples of some of the text messages that we'd send across the week, just to give you a brief idea. So what were my results? We had 61 adults participate within the trial. We got significant time by condition interactions for all of the outcome measures, for weight, waist, BMI, dietary adherence, physical activity adherence, self-efficacy, all of them, which was good. We were therefore able to conclude that the addition of telephone and text message support improved lifestyle intervention adherence and clinical outcomes when compared to standard care, and that within both groups, participants did far better when they were receiving the telephone and text message support, which is exactly what we wanted to see. I wanted to be able to show that if we were able to offer participants more regular patient-provider contact and more frequent behavioural treatment, they would fare better in both their adherence and their clinical outcomes, and that's what we were able to show, which was great. I'm just briefly going to show you just some of the figures to help get your head around what we came up with. So this graph, for example, is weight. You can see down the bottom we've got baseline 4 months, 8 months. The top line shows you the group that got the telephone and text message support within the first 4 months, moving to control. Sorry, I said I was going to stay, but I'll just walk through for 1 second. So the top line, that's telephone and text support within the first 4 months and then control, and then this bottom red line is the control within the first 4 months, baseline to 4 months, and then crossing over to the telephone and text support. So you can see that the group who got the telephone and text support in that first 4 months, the blue line, lost a significant amount of weight in the first 4 months, and then were able to maintain that weight loss over the second 4 months. The group who got the standard care or the control within the first 4 months, they didn't have much of a change in their weight loss in those first 4, but then once they crossed over to the telephone and text, they then lost a significant amount of weight. So in both groups, they did better while receiving the telephone and text support. Similar story for self-efficacy for diet. They had huge improvements to their self-efficacy in the first 4 months when they were receiving the telephone and text support, and then they managed to maintain those improvements over the second 4 months. As opposed to the other group who got the standard care in the first 4 months, they didn't have a lot of improvement to their self-efficacy in those first 4, but once they crossed over to the telephone and text, they had huge improvements. So you can see again that they did far better in both groups when they received the technology-based support. And just finally, for physical activity, same story, huge improvements in their number of steps that they were doing when they were receiving the telephone and text support for the blue line, the top blue line going up, and then they maintained those improvements after crossing over. The other group, they didn't do so well on their steps. They went down in their steps for the first 4 months in the standard care, and then once crossing over, they did better. So I'm rambling now, but you can see that it's a similar pattern across all of the outcome variables, that they did far better while receiving the telephone support, which was great. Okay, so what are the implications of the research? Given the real-world context of the research, the fact that we've done it in a real-world community-based setting, the findings make a really important contribution to both research and clinical realms by informing possible improvements to obesity management service delivery, as well as to the field of health behaviour change. There's lots of different broader services that offer health behaviour change coaching, such as diabetes services, and the research is applicable to those services also. Technology offers services a really unique opportunity to be able to provide additional support, motivation, accountability, feedback, reminders, prompters, all of those things between their scheduled clinic visits, all via a really cost and time effective platform. It therefore alleviates pressure on services that are under high demand with finite resource constraints. Further research would be great, wouldn't it always be great, to be able to investigate the scalability of the intervention over larger patient numbers, longer time periods, and I'd also like to look at other forms of technology, websites, phone applications, emails, Skype, that sort of thing. So that's what we'll look towards next. So just briefly, I wanted to touch on the next study I did after that one, which was just a qualitative process evaluation of the RCT. So I did this because I just wanted to be able to get qualitative insight to the participants' perspectives and experiences of how they found the trial. We know it was effective quantitatively, but did the participants even like it? So we ran 3 focus groups of the participants who were part of the trial and analysed the data using thematic content analysis. The feedback was overwhelmingly positive. Participants reported they felt highly encouraged, motivated, supported throughout the intervention period. They knew that they were doing far better while they were receiving the telephone and text support, and they found the mode of communication really simple, really convenient. So everybody that came along to the focus groups loved the trial, and it was overwhelmingly positive feedback, which was really good. This is my thematic network, so don't study it too hard. It's a bit of a busy slide, but it's just showing that patients loved the focus and accountability that they got. They felt encouraged and supported. They found the intensity of contact great when asked whether they would want more telephone calls or less, or more texts or less. Everyone seemed to think that the monthly call and 3 text messages a week was ample and was what they were after. There wasn't any dramas with any of the trial, really, so that was good. Okay, so I'm going to open up the floor to any questions we might have, but just a brief thank you to my supervisors, Associate Professor Kate Pumper and Professor Peter Hassman. I've had the same 2 from start to finish, which has been great. So a huge thanks to them for helping me get to the finish line. Okay.
Do we have any questions?
Exciting results, Emily. It's fantastic. I'm wondering, so on the charts, the weight loss was about 5 kilos for that period of time, which doesn't seem a lot, but, what did you feel about that? Were you expecting more?
No, we were thrilled with that. Within the obesity management service and within Class 3 obesity, getting weight maintenance is a huge goal for us, stopping the weight gain profile. So to be able to stop that weight gain and still elicit extra weight loss was actually really good compared to what we usually see within that clientele group. We managed to reach, in the end, I think about 8% weight loss, which was over the 5% we usually would like to see. So yeah, no, we were pretty happy with those weight loss. Participants, maybe not so much. Everyone always wants to lose 30 or 40 kilos. But in terms of what we usually see within that research field, yeah, we were happy. Yeah.
Thank you very much. I'm very sorry I came in late, but the results looked wonderful. I don't know how you see this, but with the crossover, it looked like there wasn't a sort of continuing effect once people did cross over, which I guess speaks to humanity. But are you envisaging that this would then be something in the future that would be a continuous nudge that people would be on indefinitely, because there doesn't seem to be a carryover effect?
Yeah, good point. We were able to show that people maintained the improvements for the 4 months, but not that they would continue to make the improvements themselves. So I guess to begin with, I was happy that the improvements were at least maintained. I was worried that it would maybe drop off completely, but the fact that they maintained what we had been practicing was a good thing. But yeah, I think long term we will be implementing it as an ongoing service. We're actually implementing it with the obesity management service at the moment, and SKIP, the child obesity service, is implementing it. And yeah, there's no sort of cut-off time for that. We'll be rolling it out for the time people are with the service. But obviously people aren't with our service forever. Eventually they do move on. So yeah, that's a tricky one. It will be an ongoing thing, but at the same time there has to be an endpoint. What we found within the focus groups was that people suggested maybe having more of a taper of the support would be good, because I just did the monthly telephone call and the 3 texts up until a point and then stopped it. Whereas it's obviously, in practice, would be a good idea if we could begin to taper it off, make it maybe a bi-monthly phone call and 1 text message a week for a little while, and taper the support a little bit might be a way to go forward. But yeah, to answer your question, yeah, we will be rolling it out on a continuum basis. Yeah.
Thank you.
And can you comment on the feasibility of time commitment to keep rolling that out for patients beyond, say, 4 months?
Yes. So in theory, the way that I envisage it is that it's saving time and it's saving money, because it's allowing us to take the pressure off the face-to-face support. We do spend a lot of time doing face-to-face clinical support with all services, and sometimes all patients need is a phone call check-in. They don't necessarily need to come in for an hour consult. They don't need to take time out of their own day and have a whole hour consult with us, just for us to check in and see how they're going. Especially in obesity management, often participants are just needing a bit of motivation and support and to answer a couple of questions. So it's obviously an adjunctive tool to face-to-face care. I don't envisage we'll take that away, but I think it will take the pressure off having quite so frequent appointments. So even though it does take time to call and to text people, I do myself see it as a time-saving factor, because it helps to take that pressure off the face-to-face support. And it's pretty quick to write text messages. I mean, I would do the phone call and then I'd write all 12 text messages for the month straight away, and I'd pre-populate it onto the system that would send it. So I wasn't getting on my phone every 3 times a week to text somebody. I would do all of the text straight away after the phone call. It was all individualised text, but I'd do it over the month, and then it would get sent out automatically. So it only took me an extra 20 minutes or so after the phone call to do it, but for such a huge impact on somebody, getting those texts so frequently, I think the time that it involved, the impact is far greater than when you bring somebody in for an hour. Yeah.
Hannah?
So this is, I guess, leading on from Christian's original question. Is there any evidence that shows what the longevity of this type of thing is? So at what point do the text messages and phone calls kind of get ignored? So, you've done your 4-month thing, maybe it's gone to 5 weekly for a year or whatever.
Yeah.
What's the evidence about how long it will really last, or how long will people actually take notice?
Yeah, good question. There's no evidence about that. As I said, this is the first study that's looked at using telephone and text conjunctively with a program, or as an adjunctive tool to a standard care program. So it's the first time that it's been done in general. Nobody's looked at using it longer term. In terms of people who use it compared to no contact or compared to standard care, I think they have fairly long-lasting effects, but it's not really a comparable question because you're comparing it to no contact or you're comparing it to somebody who has just, email handouts or something that's just not comparable. So they get success rates that's fairly long-term, but I can't say. We'll need to do the research looking at it over a longer period of time to be able to answer that. So it's good that the study's novel, but at the same time, there's not enough research for me to be able to compare what it will be looking like when we scale it to a bigger scale and when we do it over a longer period and when we do it with more patients. And also, I individualised all of the texts. I found that really important to individually tailor all of the messages, and the participants in their focus groups said that individually tailoring the text messages was hugely important to them, and if it had just been a generic message, they wouldn't have felt very supported. But at the same time, it saves a lot of time and money to make it a templated text. So that's another thing that could be done in research. What would it look like if you did a templated text? Would it save the time? Would it save the money? Could you do it over a longer period? But then you'd have the offhanded cons of that as well. So there's a lot more research needed to be able to roll it out, into lots of different services. But good question. Not sure.
Would you join me in thanking?
Thank you.
Lots of interest there, which I'm sure you can follow up at the break. Our next speaker is Elizabeth Webb from the Physiotherapy Department at the Calvary Hospital, and Liz is going to speak to us today about the effect of compression therapy in cellulitis. Thanks.
No, I'll stay here. Alrighty. So today I'm really excited to discuss the results of a randomised controlled trial which assessed if compression therapy can prevent recurrent cellulitis. But first, what is cellulitis? Cellulitis is a really common bacterial infection of the skin and the tissues beneath the skin, which often requires antibiotics for treatment. Most episodes occur in the lower limbs, and symptoms include pain, heat, redness, and edema. In Australia, cellulitis is the 4th most common reason to visit an emergency department, with almost 130,000 presentations per year and subsequently over 66,000 hospitalisations, which on average last 5 days. And these numbers don't even include GP and community managed cellulitis. One of the big problems with cellulitis is its recurrent nature. In a 3-year time frame, cellulitis reoccurs in up to 47% of patients. Chronic edema is a strong risk factor for cellulitis, and the relationship between cellulitis and chronic edema is a vicious cycle. With each episode of cellulitis, the lymphatic system is further impaired, increasing chronic edema and residual edema and increasing risk of future infections. And we really want to stop this cycle. Compression bandaging and daily wear of compression garments are used to control edema. Expert opinion suggests that compression therapy should be used in patients with chronic edema to prevent recurrent cellulitis. However, there are currently no randomised controlled trials to support this theory, and therefore it is not always standard practice. To address this knowledge gap, we designed and conducted a randomised controlled trial. The primary aim was to determine if compression therapy can prevent recurrent cellulitis in patients with lower limb chronic edema. Secondary outcomes included cellulitis-related hospitalisations, quality of life, and limb volume, although the study was not powered for these outcomes. Patients were allocated to either receive education about cellulitis prevention or education plus compression therapy. Eligibility criteria included the presence of lower limb chronic edema and a history of 2 or more episodes of cellulitis in the same leg in the 2 years prior to trial referral. Once patients were enrolled and baseline measures were completed, block randomisation using sealed opaque envelopes was used to allocate patients. Randomisation was stratified based on prophylactic antibiotic use, and we aimed to enrol 162 patients, completing 6 monthly follow-ups for 3 years or until 45 episodes of cellulitis occurred. Control group participants were crossed over from the control group over to the intervention group following their first episode of recurrent cellulitis. And this was to ensure no participants continued to experience cellulitis recurrence without receiving our institution's standard practice. There was no blinding of assessors or participants due to the visible nature of the treatment and the lack of feasible sham interventions. Prior to trial commencement, we planned an interim analysis by an independent data monitoring committee after 23 episodes of cellulitis and agreed on stopping criteria. To assess if compression therapy prevented cellulitis, we measured time to cellulitis recurrence in days. Independent diagnosis of cellulitis was conducted by the participant's GP or their treating physician who were independent to the trial. To assess change in leg volume, a 3D scanning device was used to assess leg volume between 6 and 40 centimetres up the leg. And these measures were used to decrease risk of bias that might occur through lack of therapist blinding. So, 84 participants were enrolled and randomised. Only 4 were using prophylactic antibiotics, and these were evenly allocated between groups. In February this year, we recorded our 23rd episode of cellulitis, which triggered our pre-planned interim analysis. The results met the stopping criteria, and the data monitoring committee advised that recruitment and the trial should be ceased due to the clear clinical effect. Who do we have? So baseline demographics were fairly equal between the two groups. Chronic edema was bilateral in 79% of patients. The average age was 64, and the average BMI was just a little bit higher in the control group. In the 2 years prior to the trial, the average number of episodes of cellulitis per leg was 2, and the average number of cellulitis-related hospitalisations was 1. Now the exciting bit. This figure here tells us the probability of cellulitis reoccurring in each group over time, taking into account follow-up of every participant. The y-axis is the percentage of participants without recurrent cellulitis, and the x-axis is time in days. And each step down in these curves signifies an episode of cellulitis. So we can see that the red line is the compression group and the blue line is the control group. Not only were there fewer episodes of cellulitis in the compression group, but they also tended to occur much later than those in the control group. And in comparing these two groups, the log rank test was found to be highly statistically significant. Cellulitis reoccurred in 40% of the control group compared to only 15% of the compression group. An analysis showed a hazard ratio of 4.4, meaning that those in the control group were 4.4 times more likely to have an episode of cellulitis than those in the compression group. The results also indicate that we only need to treat 4 patients to prevent 1 episode of cellulitis. And not many medications can really claim this level of effect. In fact, a recent RCT conducted in the UK that compared the impact of prophylactic antibiotics in patients with recurrent cellulitis found a number needed to treat of 5. Next, this graph here shows leg volume over time for both groups. Over 6 months, on average, the control group leg volume increased by 26 mils, whereas for the compression group it decreased by 88 mils. And over 18 months, this equates to a difference in leg volume of 339 mils, which is close to the volume of a can of Coke. This result was also highly significant. So strengths of this trial included use of RCT methodology, selection of outcome measures to minimise risk arising through lack of therapist blinding, and use of broad inclusion criteria to increase the generalisability of the results. Limitations included our reliance on physicians' diagnosis of cellulitis. So this trial is the first in the world to show that compression therapy can prevent recurrent cellulitis in patients with chronic edema. The clinical implications of this are that compression therapy should become standard international practice for patients with chronic edema experiencing recurrent cellulitis. And translation of this evidence into practice may even reduce antibiotic use. Further research is now required to determine the cost-benefit of prescribing compression to prevent cellulitis. And obviously I'd like to thank my wonderful lymphedema team and my PhD supervisors, particularly Bernie Bissett and Terry Neiman. Thank you.
A wonderful outcome and great presentation. Do we have some questions for Lizzie? Catherine.
I suppose, as an occupational therapist working in the community, a big thing that we see a lot is people having difficulty managing their compression garments. And I was just wondering what your experiences are and what the literature might say about this sort of thing ongoing, because this sounds fantastic if we can prevent this sort of thing happening, but that ongoing compliance, I should say, with regards to managing compression garments.
Yeah, absolutely,
Ongoing.
absolutely. So in this trial, we didn't exclude anyone because they couldn't put compression on, and I can say that nearly every single person that went into the trial was able to don and doff compression therapy by themselves. We use different types of compression depending on the patient's needs. So for some people we use compression wraps which Velcro up. For other people we use donning and doffing aids. But all of them were able to independently get the compression on and off. Or some people did have assistance from carers as well. But on the whole they were getting them on and off. We have assessed compliance, and I haven't looked at that data yet. I'd be interested, but compliance was pretty good. And compliance has just got better after we've told people their risk of cellulitis is much lower. And so now that they know we're preventing them ending up in hospital, they're even more motivated to keep wearing that compression therapy because, I mean, a cellulitis admission, it's often 5 days. It really knocks people about. It takes them out of work. So if they can prevent that, they're often happy to put in the effort.
Actually, I might get people to hold questions now for morning, afternoon tea if you could. So would you join me in thanking Elizabeth? Our next presenter is Jane Van from Cardiology here at Canberra Health Service, and she'll be reporting on the incidence of arterial fibrillation in stroke workup patients. Thank you.
Okay, good afternoon everyone. My name's Jane. I'm a cardiac physiologist from the cardiology department, and today I'll be talking about a quality improvement project which looked at the incidence of atrial fibrillation in stroke workup patients identified by 24-hour Holter monitoring. So, strokes are a major global health problem and remains the second leading cause of death worldwide, affecting approximately 15 million people per year. In approximately 1/3 of all ischemic stroke patients, a cause cannot be determined for the stroke, and this is classified as a cryptogenic stroke. Atrial fibrillation is the most common recurrent cardiac arrhythmia faced in clinical practice. It affects 33 million people worldwide, most commonly seen in the elderly, and affects up to 5% of the Australian population. This arrhythmia arises when electrical activity in the atria, or the top chamber of the heart, is chaotic and disorganized. This causes the atria to fibrillate, or to quiver, rather than contracting uniformly, and causes an irregular heartbeat. AF episodes may last for seconds, minutes, hours to days. When the heart spontaneously returns into what we call normal sinus rhythm, within 7 days, it is known as paroxysmal. If AF episodes occur only paroxysmally, it makes the arrhythmia extremely hard to detect. AF can be persistent, lasting between 7 days up to a year. It can be long-standing, lasting over a year, where a rhythm control strategy is in place, or it can be permanent when there are no more efforts to return a patient into sinus rhythm. So, stroke is the greatest risk for those who have this arrhythmia. Due to the fibrillating motion, the blood can pool in the atria, causing a procoagulation environment. This gives potential for a blood clot to form in the atria, for it to dislodge and go into the bloodstream and up to the brain to cause a stroke. So AF is associated with a 5-fold increase in risk for a stroke. It is the leading preventable cause for recurrent strokes, and AF has actually been identified to be the cause of up to 20 to 30% of cryptogenic strokes. Therefore, early and sensitive detection of AF is extremely vital to commence appropriate anticoagulation therapy for stroke prevention and to maximise positive patient outcomes. So within the cardiology department, Holter monitoring is a diagnostic investigation readily provided to both inpatients and outpatients. Holter monitors are small portable devices used to detect cardiac arrhythmias. Most commonly, the non-invasive devices are performed over a 24-hour period. However, they can be performed for multiple days. The devices are widely applied to stroke workup patients for the detection of AF. Currently, at the Canberra Hospital, stroke patients will undergo prolonged cardiac monitoring for a week up to a month if there's a really high suspicion of a cardiogenic cause, such as AF. Patients will receive 24-hour Holter monitoring if there's quite a low threshold for thinking that there's a cardiogenic cause. So, this assessment is mostly conducted on inpatients, and it often prolongs their stay in hospital and delays their discharge. So despite the widespread use of Holter monitors for AF detection, their clinical utility remains quite unclear, with detection rates currently ranging from only 1% up to 12%. So therefore highlighting the need for research in this area. So the objectives of this study was to identify the positive percentage yield of AF detection using 24-hour Holter monitoring in stroke workup patients. The study also aimed to assess the association between AF and age, gender, and burden of atrial ectopic beats, which are just extra beats that originate from the atria, as predictive risk factors for AF. So based on existing literature, it was hypothesised that there would be a low percentage yield of AF detection by Holter monitors. It was also hypothesised that males would have, that AF patients would be more, AF would be more common in males than in females, that AF patients would be older than those without AF, and that AF patients would have more atrial ectopic beats compared to those without AF. So this was a retrospective observational study looking back at 4 years of data. This data was obtained from Cardiobase, which is a system in cardiology that we use to store diagnostic results. The population included retrospective patients, male and female, both inpatients and outpatients, who had a Holter monitor for the indication of a stroke workup. Exclusion criteria in the study was very limited, and we only excluded patients who had missing data from what we needed for the study. Multivariate statistical analysis was used to analyse the data and to determine statistically significant associations. So in the study, 820 patients were included. From this, 80% of the patients were inpatients and only 20% of the patients were outpatients. There were more males than females in the sample population. And of the total population, the majority were aged over 75 years old. From the 820 patients, only 25 patients were found to have AF or paroxysmal AF, and these episodes were lasting longer than 30 seconds. This gave a low percentage yield of only 3%. Within the positive AF population, patients were predominantly aged 75 years and above. Statistically, increased age and presence of atrial fibrillation was found to have a statistically significant association, and this agrees with the current literature. Of the 25 patients who were AF positive, the majority of patients were male. So it is known that women are actually at a higher risk of stroke than men. However, studies have identified that men are more at risk of developing AF earlier than women. So in this study, there were more males than females in the study. However, the differences between the two populations were not significant. Atrial ectopic activity wasn't significant either between the two populations. And a few limitations of the study. So we were only limited to 4 years, as this was when the new system was introduced. So obviously increasing the sample population will increase the statistical power of the study. The study only assessed 24-hour monitoring periods, and we didn't assess longer monitoring periods. So if we look into this more, we can identify whether longer monitoring periods increases the sensitivity of the monitoring in detecting AF. The study also didn't assess patients' medical background. It didn't assess their CHADVAS score, which assesses their risk of atrial fibrillation and stroke. So looking into this in future studies, we'll also identify higher risk patients and whether their monitoring period should be longer, whether they're more at risk of having AF and a stroke. So to conclude, this study shows that 24-hour Holter monitors only provide a 3% diagnostic yield in detection of AF. So I think that further research can identify more individualised approaches for the Holter monitors. However, an important point that comes out of this study is that although it is a low percentage yield, still 3% of patients are identified to have this arrhythmia and obviously are appropriately treated. I think that something interesting that comes out of the study is that we can think about potentially having these monitors as outpatients rather than inpatients. Obviously, this will free up a bed, it'll decrease hospital costs with delayed discharges, and obviously will provide beds to patients who need them most. Thank you.
Thank you very much. Any questions for Jane? Christian.
Thank you. Very interesting study. Just a couple of things. We wouldn't actually call a stroke cryptogenic until we were sure it wasn't due to atrial fibrillation. The actual statistic is that about 30%, 25 to 30% of ischemic strokes, all of them, are due to atrial fibrillation. And what that means is that if you actually catch atrial fibrillation, as the stroke community says, it's like gold.
Yeah,
because
exactly.
you can actually do something about it much more than you can do to people where you haven't found something like that. Mm-hmm. And so while we always appreciate that the yield, as you have demonstrated, is low, the next sort of logical conclusion that some people might draw is that it's therefore not worth doing.
Exactly.
And we would take huge issue with that, because even 3% pickup rate for the people that you pick up is fantastic.
Yeah.
And the problem is, and again something that I think you're trying to address, is can we be more selective? And I entirely agree that somebody who's going to be below 55, it's very unlikely to pick up.
Yeah.
But apart from that, we just don't have anything which is secure enough to be able to say you don't need to do it. And while we entirely appreciate that you guys are completely overworked by the fact that we keep sending you all these people and they're always negative, when you do come up with something, it's just wonderful.
Yeah.
So thank you for doing that.
No, that's okay. Yeah, I think that's a really important point, that even though it is low, there's still, 3% of the population out there that has this arrhythmia. And, if we don't do this monitoring, then they might end up having a second stroke or, something worse, or even possibly dying from having a stroke because of AF. So I think that this study wasn't to prove that we shouldn't be doing, that Holter monitors are a waste of time, because, it's not a waste of time, as this study has shown. But whether, yes, we can be more selective with the population, whether we can allow earlier discharges, but still have the monitoring period. There are a lot of times where we do put on Holters on inpatients, and they end up having to stay another night because of that monitoring. Yeah.
Great. Thank you very much. Our next presenter is Beck Cisnik. She's exercise physiologist here in the Canberra Health Services, working with colleagues at the University of Canberra, and she'll be speaking to us today about self-reported physical activity levels and barriers for inpatients with cancer. Thanks, Beck.
Hey everyone, thanks Nick. So as Nick said, my name's Beck and I'm an exercise physiologist here at the Canberra Hospital. We work primarily with outpatients, but we do see some inpatients as well. I have recently started my PhD as well, where I'll be looking at physical activity in the patients who are undergoing chemotherapy and looking at ways to try and increase that. So this cross-sectional study was, I guess, a bit of a starting point for that. We know that cancer is a huge burden on people globally. Globally, it's the second leading cause of death, and about 1 in 6 deaths are caused by cancer. Each year, the number of people that are being diagnosed is going up. However, treatment is becoming really effective, which means that people are living longer with the disease and with the treatment-related side effects that come with it. Physical activity has been demonstrated to be really important in managing the side effects of treatment, but it also helps to improve the adherence to chemotherapy, as well as reducing the risk of reoccurrence, reducing risk of death, and improving quality of life. So physical activity is really, really important in patients who are undergoing chemotherapy. But we do know that not many patients who are receiving treatment for cancer in general are physical active. So the current physical activity recommendations for patients who are receiving treatment for cancer is currently unknown, but the Clinical Oncology Society of Australia recommends the same as what's recommended by WHO for general populations. So that's looking at 150 minutes of moderate intensity physical activity or 75 minutes of vigorous intensity physical activity, or a combination of the two, as well as 2 to 3 resistance exercise sessions per week. So the aim of this study was to have a look at the physical activity levels of patients across the ACT who are undergoing chemotherapy for the treatment of cancer, and compare this to the physical activity guidelines, having a look at how many were reaching that criteria. I also wanted to have a look at the barriers that they were reporting to physical activity, and compare this to what was published in the research for similar populations, as well as understanding if patients within the ACT felt like they were actually getting enough education about physical activity. So outpatient services within Canberra don't actually have any physiotherapists or exercise physiologists associated with the unit. They definitely can be referred out to other services, and they often are, but it isn't standard care that these populations get treatment or get education about being active. So the method for the study, eligibility criteria, I was looking at patients who are aged 18 years or over and who are currently undergoing chemotherapy for any type of cancer within the study period, which was a 4-week period. The ineligibility criteria were patients who were unable to read or write English, or who didn't have a carer available who was able to do that for them. People who were inpatients throughout the period, so it was only an outpatient-based study, and also those who had the cognitive impairments that meant that they wouldn't be able to recall the information that was required to answer the survey. It was completed over all of the outpatient chemotherapy sites across the ACT over the 4-week period, so every patient over the period was given the option to partake in this study, which I think is really valuable. So here at the Canberra Hospital in the Canberra Region Cancer Centre, as well as the Zeta Mary Clinic and the National Capital Private Hospital Chemotherapy Unit as well. The questionnaire was part and part of 2 different things. It was primarily a study-specific questionnaire, which was validated by health professionals and patients prior to being undertaken. And it also used a portion of the modified Godden and Shepherd Leisure Time Physical Activity Questionnaire, which is highly used in this population group as well. After I received the data, I used t-tests and ANOVAs to compare the physical activity levels based on what patients reported their own barriers were, as well as where they said they got their education from. So it was all self-reported. So the results of the study, looking at physical activity levels initially, particularly aerobic physical activity, patients reported that they pretty much weren't meeting physical activity guidelines. So here at the Canberra Region Cancer Centre, just over 7% were meeting the guidelines of that 150 minutes of moderate intensity activity. NatCap was a little bit higher at 13%, and Calvary had 22%. I would like to say that Canberra Region Cancer Centre did have the highest number of patients included in it, and it did step down as you moved up higher as well. I think Calvary Hospital only had 22 participants at the site throughout that period. The Taiwan study that is up higher, the fourth one on the rung, that is a study that was completed with a very similar format, looking at patients who were undergoing chemotherapy, outpatients as well, and they reported that 40% of patients were meeting that 150 minutes of physical activity, whereas the general population of Australia, about 50% or 55% meet activity guidelines. So we know that not enough people in general are meeting physical activity guidelines, but particularly in patients that are undergoing chemotherapy, their levels are quite low. So overall, we had 111 people respond to the survey. It didn't quite reach the number that was required for statistical power, but we did have a 20% response rate, which isn't too bad for a population-based study. The mean age was about 60 years old. There was more females than there were males, and not surprisingly, the largest types of cancer were the digestive system or were breast cancer-based patients. However, surprisingly, over 20% didn't respond to that question as well. The graph up there is looking at what patients reported their barriers to physical activity were. And you can see the biggest standout there is fatigue. Cancer-related fatigue is a really big impactor on patients diagnosed with this condition, and somewhere between 70 and 90% of patients usually do report cancer-related fatigue. So it's not surprising that a lot of people have reported this one as a barrier. Some of the other largest barriers up there are pain, strength, but then also motivation as well. The patients were asked in the survey who had provided them education on physical activity levels, knowing that there aren't standardised approaches to who does provide this education throughout their care. So 22% of patients responded that no one had provided them any education at all, which is an area that definitely needs to be fixed. The most frequent provider of education were the nursing staff, which from my understanding was done throughout the consults where they were receiving their chemotherapy particularly. The other top providers of education were their specialists, their GPs, and then fourth was the exercise physiologists. So the conclusion or the results that were found was most patients within Canberra that are undergoing chemotherapy are not reaching physical activity guidelines. Overall, once combined together, I think it was about 10% of patients actually met the physical activity guidelines of 150 minutes of aerobic intensity. Largest barriers to physical activity were primarily based on the side effects of treatment, which is really important because we know that physical activity does actually help to improve a lot of these side effects. So being able to help patients to understand how to exercise with them can then result in reducing the side effects, which then makes physical activity easier, and it will be a little bit of a rolling ball for that as well. Some types of education seem to be affected a little bit more, seem to affect the types of, some sources of education seem to affect whether people were physically active or not. GP was actually significantly related to whether participants were involved in mild intensity exercise, so not that moderate, but at least they were trying to be active throughout their day, whereas referral or education provided by an exercise physiologist was significantly related to people doing more resistance-based exercise. None of the other sources of education had any impact or any significant impact on physical activity levels that were there. So clinically, this is a really important study from an ACT point of view. It's showing us that our patients aren't meeting physical activity guidelines. We know that it's really important for them to do so. The evidence is out there in terms of treatment adherence, in terms of side effects, in terms of reoccurrence and mortality rates. So we really need to have a think about what we can actually do to help this population increase their activity levels. Most of the highest causes or the highest barriers reported for not being physically active were a result of the treatment-related side effects. So providing education about how to be active throughout these periods, individualising programs and approaches for people to be active is going to be really important. And education from certain sources really did increase the amount of activity that people were doing. COSA recommends that physical activity be provided by all members of the cancer treating team, which particularly considering 22% reported that they hadn't received any education, that's something that's going to be really important to push. We can't guarantee that people are going to be referred out to exercise physiologists or physiotherapists, so it's going to have to be something that's taken on by the whole team. However, if they can be referred out to services that are there are public and private services available for these populations, and that can definitely help and get more tailored and individualised advice. Yeah, thank you.
Now I'm losing control of the control I'm supposed to have of the timing. So what we might do is hold the questions for Becca till afterwards. And I might invite the next speaker, Jane Desborough, to come up, please. Thank you. Jane is from the ANU and is working with colleagues here at Canberra Health Services, and they've been exploring the there's a team. The unplanned 30-day readmission for lower limb arthroplasty patients. Thank you.
Thank you. So I know you expected one, but we have had three of us, myself, Madja and Sybil, have stood together at a desk playing with data and with this data for a long time over the last 6 months. So it only seemed intuitive that we stand at this desk and present the results together. Most of the students, we hear students thanking their supervisors. One of the greatest pleasures of being an academic is working with students. So I'd like to thank Madja and Sybil for making this last 6 months just so much fun working with this. So I'll introduce, they'll present their bits and I'll close off. Great. So, internationally, unplanned 30-day readmission to hospital is an indicator of the quality of care and an indicator of health system performance. It may reflect poor quality of care or coordination in the hospital and or in transition to the community. While not all unplanned readmissions are unnecessary, it's estimated that 25% are avoidable. Patients' healthcare journeys primarily take place in their homes and communities and are occasionally integrated with the community in the acute care sectors. This requires that they are well prepared to make decisions regarding their health. One measure of patients' ability to manage their health is patient enablement. Having the knowledge, means and ability to manage one's health and life. One author, Krumholz, proposes that a challenge to patient enablement is post-hospital syndrome, where patients' experiences in hospital result in a transient period of acquired vulnerability, diminishing their ability to understand and comply with discharge instructions or to effectively resume their daily life, placing them at greater risk of unplanned 30-day readmission. We developed the ACT Transition from Hospital to Home Orthopedic Survey to examine associations between individual, hospital and general practice variables and unplanned 30-day readmissions. The instrument included information about patient demographics and comorbidities, post-hospital syndrome, medication and patient enablement, attendance to rehabilitation and transition to general practice. We conducted a cross-sectional survey from the 1st of February 2018 to the 31st of January 2019 with public patients from ACT Health and Calvary Public Hospital and private patients from Orthopedics ACT and Canberra Hip and Knee Replacement. We used multiple logistic regression analysis to examine the associations between independent variables and our outcome of unplanned 30-day readmission. Now, our overall results, we had a 64% response rate, 5% of whom were readmitted within 30 days of discharge. We found that public patients were significantly more likely to be readmitted within 30 days than private patients. Hip surgery patients were significantly more likely to be readmitted within 30 days than knee surgery patients, and patients who did not feel well rested on discharge were significantly more likely to be readmitted than those who did feel well rested. We then decided we thought it would be a good idea to separate this data, so to look at the hips and the knee patients separately and to see if that had, what impact that had on these results. So I'll now hand over to Madja.
Hi everyone. So I'm going to discuss the results for knee arthroplasty patients. The readmission rate among these patients was 4%, and out of these 35% were public patients and 65% were private patients. Also out of these, public patients were significantly more likely to be readmitted than private patients, and patients who attended rehabilitation were significantly less likely to be readmitted than those who did not. Now, the median waiting time for a knee replacement procedure was 196 days for public patients compared to 57 days for private patients in Australia. By the time public patients have their surgery, it is likely that their joints are in much worse condition than their private patient counterparts. Attendance to rehabilitation has also been associated with higher physical function in patients compared with those who do not attend in previous studies. Although no difference in outcome has been found between inpatient rehabilitation and home-based rehabilitation. And there's a range of patient and provider-based factors that affect rehabilitation pathway chosen by patients, such as preoperative factors, previous experiences or experiences of known others, perceived benefits, and clinical status post-surgery, as well as insurance provider and hospital business model.
Good afternoon, everyone. I'll be discussing the results from the hip arthroplasty population group. For hip arthroplasties, there were 431 patients that completed the survey. 27 were readmitted. This represented a 7% readmission rate. The majority of surveyed patients were private patients, making up 73% of this group. After controlling for age and gender, those that did not feel rested upon discharge and those with peripheral vascular disease were significantly more likely to have an unplanned readmission 30 days later. Hospitals cause disturbances in patients' sleep patterns, leading to a reduced amount of sleep at a time when the body is working to recover from the assault of surgery, pain, and medication. So in terms of feeling poorly rested upon discharge, we believe that due to the busy environments of hospitals, patients' sleeping patterns are being affected during what is considered to be quite a critical time period following surgery. There could be a number of ways that the quality of rest a patient is getting may be negatively affected. For example, the sharing of a room, the ambience of the room, the sounds of the machines, the proximity to nursing stations, and the constant monitoring of vital signs by other health professionals. All of these different factors could lead to patients feeling poorly rested upon discharge. The other significant factor is the presence of peripheral vascular disease. Peripheral vascular disease is often underdiagnosed as it can be asymptomatic, and when symptoms do occur, the condition may already be quite advanced. Patients with peripheral vascular disease may have vascular changes that affect the wound healing process. Adequate perfusion is needed for vascularization, tissue regeneration, and removal of toxic substances from the surgical area. Therefore, having comorbid peripheral vascular disease appears to be implicated in 30-day readmission rates following hip surgery.
So while we had a good sample size and diversity of patients, the number of patients with the outcome of interest, 30-day readmission, was small. Oh, the N, which isn't on this slide, was 40 overall. So we do need a much larger sample size to increase the power of this study. It was a patient-reported outcome, and because of the anonymity of this survey, we were unable to check the accuracy of self-reported readmission with medical records. So what are the implications for policy and practice? We believe these results provide incentive for hospitals to develop strategies that provide more equitable waiting times for public and private patients, in particular to reduce waiting times for public patients, encourage patients to attend rehabilitation, informing them of the benefits, ensuring same access to services for both public and private patients, maximise rest and sleep during the hospital stay, and ensure optimum treatment for peripheral vascular disease prior to total hip arthroplasty. We'd like to thank our co-authors, Diana Perryman, who's here. There's actually a cast of thousands in this, who assisted with the development of the survey as well. Thank you.
Again, we might just keep rolling through the presentations. Thank you very much for your presentation today. Could I invite Maureen O'Brien? Here we go. Maureen's from Canberra Health Service, and she'll be speaking to us today about advanced care planning perspectives amongst those with Parkinson's disease. Thank you.
Thanks, Nick. But there is a little disclaimer here because I'm not Maureen O'Brien. My name's Anne Noble, and I'm very proud to call Maureen an inspirational colleague and a friend. And I'll be talking today about Maureen's research on her perspectives of advanced care planning amongst those with Parkinson's disease. This is Maureen. She's having a lovely time in her native Scotland. She's having a lovely time. Maureen completed her master's degree in 2017, and this research provides, even though a small scale, provides valuable insight into the motivation and the uptake and engagement of advanced care planning in people with chronic disease. So just to remind you, Parkinson's disease is a progressive degenerative neurological condition which affects over 70,000 people in Australia. And after 8 years, 80% of people will have cognitive impairment. There are associated verbal and non-verbal communication problems within the Parkinson's disease. Cognitive decline and these communication issues affect the timing and the initiation and the ability to engage in the advanced care planning process. So advanced care planning, and this is where my expertise comes in as I'm an advanced care planning project officer. Advanced care planning is a process that involves a series of ongoing reflective conversations. Future care decisions are based on a person's values and preferences, should they be unable to decide or communicate those preferences due to limited speech and cognition. Preferences may be documented in an advanced care plan, and a substitute decision maker can be appointed. And advanced care planning is a voluntary process. We know there's a lot of benefits. It improves end-of-life care, it empowers patients and their families, and it does improve quality of life and enhances feelings of control and hope. But yet, uptake is really low, and we have between 1 and 12.5% of the adult population in Australia have advanced care plans. The emphasis is often very much on the completion of advanced care plans rather than the conversations. And there's a lack of evidence on the experience of advanced care planning in people with Parkinson's. There are a lot of critics about advanced care planning, so it does limit conversations and it does subsume patient-centred care. What Maureen wanted to know was how people living with Parkinson's in the ACT understood and experienced advanced care planning as their disease progressed from their own perspective. The approach, as here, qualitative exploratory design, after exclusion criteria, 51 participants were considered eligible and 20 considered to participate, and semi-structured interviews were conducted and analysed and interpreted within a framework. That framework was self-determination theory, and self-determination theory contends that individuals have intrinsic and extrinsic motivators and that they experience wellness when their psychological needs are met in relation to their competence, relatedness and autonomy. So self-determination theory is addressing the social conditions which affect individual motivation. There she is again, summer. Summer in Scotland. So the findings suggested that a sense of relatedness helped to maintain a social life and foster social learning and preparation for deterioration, death, and end-of-life care extending beyond death to funerals, wills and legacies. Everyone's happy to read those quotes for themselves. It's okay, I don't need to read it for anyone. Self-mastery to manage life and social activities was important to participants to adapt to managing life with a degenerative illnesses such as Parkinson's. Focus on the living before the dying. Participants also learnt from those in a similar situation to help to imagine their future care needs. And more than half of the participants, so it's not a great number, had documented preferences for end-of-life care and treatment in an advanced care plan. However, the majority of participants weren't clear about the purpose, the content or the location, and some had specifically chosen not to do an advanced care plan. This is interesting. When values, goals and preferences arise from the authentic self, authentic choice can be realised. And when they do not, options may be picked and ticked rather than chosen, which is akin to a false choice. It would have been rude of me not to go into hospital and have it. There are also threats to family harmony or social relations cause participants to defer making advanced care planning decisions or not to make them at all. So both people needed to be ready. The family needed to be on the same page. And risk, probability and denial was considered by those with no advanced care planning, the metaphorical bus. So participants' experience of advanced care planning in this study alert us to the broader context of a person's life rather than just the narrow focus of their disease. And the losses where individuals experience due to their advancing disease need to be understood just not in the context of their social life and not just simply interpreted as a medicalised journey towards death. This was quite a small sample, and what's clear is that advanced care planning is, and it can be, more than choices for life-prolonging treatments and preparation for risk and deterioration. And I think from my perspective, and this research is quite valuable because it assures me that how I approach advanced care planning is quite important, that we need to make it as an extension of the individual. We need to make sure it's about their loved one's care and treatment as well as their own. And it's an avenue for them to remain autonomous. And we need to offer direction and support for those around them, for all of them to live as well as they can for as long as they can. And advanced care planning is very much about what matters to someone rather than what's the matter with them. And if we can engage people and have this motivation to have authentic choice, then advanced care planning will be a useful tool because it will be their voice for the future. It will be very relevant and useful to their future health journey. There are next steps. Maureen's study is being replicated in New Zealand. I'm very happy to pass questions on to her about the study. I'm also very happy to answer any questions about advanced care planning. But it's a valuable insight into something that is very small uptake, unfortunately.
Great, thank you very much. And Anne, thank you very much for stepping in for Maureen. Greatly appreciated. All right, we're almost there. We have one more presentation. Katie Spear in Exercise Science at UC will present to us on the validation and reliability of a device for measuring heart rate variability in pediatrics.
Thanks for that introduction. With that being said, I'd like to introduce you to my study, entitled The Validity and Reliability of a Photoplethysmography Device for Measuring Heart Rate Variability in Pediatrics. Health and fitness states are largely governed by autonomic nervous system, or ANS functionality. As one of our main homeostatic regulation systems, the ANS connects the brain with the body through its two branches, the parasympathetic and sympathetic nervous systems. These systems continuously react to physiological, psychological, and environmental stress. Under acute stress, the sympathetic nervous system activates fight or flight to ensure short-term survival. This type of stress is beneficial, resulting in improved brain function, health, performance, and resilience. On the other hand, chronic stress may lead to allostatic load and chronic disease. For children, sustained stress may elicit ANS dysfunction, characterized by an imbalance between SNS and PNS activity, which can act as a risk factor for many chronic diseases. Functional regulation of the sympathetic and parasympathetic nervous systems is conducted by the vagus nerve. It enables communication between the brain and several other organs, helping to maintain metabolic homeostasis by controlling heart rate, blood pressure, and other essential life functions, namely immune regulation. During stress, vagal activity is reduced, resulting in a pro-inflammatory state. Without resolution of stress, there's an excessive production of pro-inflammatory cytokines, which likely contributes to the dysregulation of many biological systems and the development of chronic disease. Considering those of a cardiometabolic or psychological origin, vagus nerve activity is reduced and linked with chronic inflammation. Lucky for us, the vagus nerve works in a bidirectional manner. This indicates that increased activity from vagal stimulation may have anti-inflammatory effects. Considering that the vagus nerve innervates the heart, insight into ANS activity and the stress response can be measured by recording heart rate variability, or HRV. Regarded as an independent physiological marker to interpret parasympathetic contribution of total ANS activity, HRV quantifies the variation in time between consecutive heartbeats. This variation, which I'll refer to as interbeat intervals, illustrates the relationship between stress and disease by reflecting cardiac vagal tone. A lower HRV may offer clinical insight into inflammatory-based chronic disease risk and identification. Furthermore, early identification of ANS dysregulation through measuring heart rate variability may help to prevent adverse health outcomes later in life, especially since rapid ANS development occurs in early childhood. The effects of physical activity interventions on adult HRV has demonstrated links between physical activity and increased HRV. In pediatrics, a study consisting of 7 to 11-year-old children found that regular high-intensity exercise training increased HRV. Analysis of HRV 4 months after the program had ceased revealed a subsequent decrease in HRV. Similarly, a recent study in 10 to 13-year-old children found that HIIT training resulted in increased vagal tone as well. Whilst HRV reference values have been established in adults and older children, there's limited research regarding HRV norms and clinical reference values in younger children. Keeping in mind the known benefits that exercise imparts on both physical and psychological health, HRV can also be used to track the response to various types of physical activity interventions aimed at managing or reducing chronic stress. So, how do we measure HRV? Well, electrocardiograms are considered the gold standard for measurement in both adults and children. However, HRV-derived ECG measurement is costly and often inaccessible to caregivers, coaches, researchers, and the general population. Over the last decade, commercially available HRV measurement devices have been developed, resulting in improved physical and psychological well-being and exercise training optimization. Many of these devices use photoplethysmography, or PPG, which is a technique that predicts interbeat intervals taken from readings at the forearm, wrist, ear, finger, and that's how they calculate HRV. PPG systems have been validated for use in adults, but we don't know whether PPG HRV measurement is valid and reliable for use in young children. As such, the purpose of this study was to determine the validity and reliability of a PPG system to measure pediatric HRV. With that in mind, we conducted a validity and test-retest reliability study to compare a commercially available finger monitor PPG HRV device with a chest belt that's been validated against ECG. 16 children with a mean age of 4 years were recruited. Short-term, seated, and resting HRV measurements were recorded for 3.5 minutes, with the first 30 seconds acting as a stabilization period. Participants were silent and still during the recordings whilst being read a storybook. Participants were measured from 8 to 10 a.m. in the morning. To determine the relationship between the finger monitor and the chest strap, paired sample t-tests, Pearson's correlations, and Bland-Altman analyses were performed. The Hopkins method of interpreting magnitude was used to describe the specific HRV parameter effect sizes. Based on the analysis of the 3-minute recording, only mean interbeat intervals and heart rate were found to be valid measurements, whilst none of the HRV parameters demonstrated validity for the PPG system. Mean heart rate and interbeat intervals also demonstrated some reliability for the PPG device. However, the chest belt demonstrated greater agreement for all HRV parameters. Considering between subject variation, the chest belt yielded moderate to good reliability with mean interbeat intervals and the SD1-SD2 ratio showing the best results. Similarly, the chest belt displayed better within subject variation with RMSSD, interbeat intervals, and mean heart rate showing the lowest values. Regarding the two relationships, reliability is generally worse for the first compared with the second. However, this is likely due to familiarity. So on the first day, children were less familiar with myself, the other researchers, the testing procedures, and equipment. But this improves on the second and third day. However, the improvement does not occur for the PPG monitor, and it's in fact worse for some parameters. This may indicate that error for the chest belt may be attributed to external influences, whilst the PPG monitor demonstrates internal error. So to our knowledge, this is the first study to investigate the validity and reliability of a commercially available PPG HRV device in children aged 3 to 5 years old. This investigation has revealed that use of the chest strap and not the PPG monitor in young children is encouraged for valid and reliable HRV measurement, specifically those parameters with strong parasympathetic input. Moving forward, with the use of the chest belt, these HRV parameters can be regularly monitored to track health and disease trajectories through exercise and lifestyle interventions in cases where autonomic dysregulation is present in young children. I'd just like to thank my supervisors, the associations, and the school at which this research was conducted. Thank you.
Great, thank you very much, Katie. Could we ask any questions of Katie and the other presenters at afternoon tea? So no, thank you very much. No, we won't hold you up right now. But could you all join with me, please, in thanking all the speakers for a very interesting and informative session. Afternoon tea is upstairs.
wait till the microphone comes to you because we are live streaming. So to begin the session, I'd like to invite Claire Pearce to talk about the contested nature of obesity and the role of health services in prevention.
Thanks, Roz. Thank you for coming out on day 3 in the afternoon. Big thank you to my colleagues in chronic disease who have come to support me. And I want to begin by acknowledging the traditional custodians of the land on which we meet, the Ngunnawal people, and pay my respects to their elders past and present. So today I'm going to be telling you about my PhD research, which broadly speaking I set out to investigate the role of health services in the prevention of obesity. So I'll take you through the background to that research, but I really want to focus on what my results were and hopefully have time at the end for a discussion. But before I do that, what I want to do is I want you to think about how you as an individual and maybe we as a society perceive weight. So at an individual level, and I'm going to use a prop here, I've brought along my scales. I'm going to put them down here. I wonder how many of you would be happy to come out and step on those scales, and I'll let the audience know what your weight is, and we can have a discussion about your health, about your weight, what you should do about it. Anyone beginning to feel a bit uncomfortable that I might pull you out? Oh, one gentleman is happy to. I won't ask you to come out because you'll take up all my time. But interestingly, I think for a lot of people, they would start to feel uncomfortable, me included. You might start to think about, how are my clothes fitting? What did I have for lunch? Why is that? Why is it that we start to feel nervous when we start talking about weight? Is it possibly because of all the messages that we're constantly bombarded with about weight, all the things that we're told as an individual and as a society that we need to do about obesity? And not only that, but the social currency that's attached to weight, and obviously often the negative messages that go with that. Now, the reason for that ongoing social commentary is possibly because obesity is a growing problem. In Australia, 2/3 of us are now overweight or obese. And obesity is often connected to a negative state because of the diseases linked to obesity, things like some cancers, cardiac disease, pulmonary disease, diabetes, and so on. But there also continues to be contested ideas around obesity. For example, is obesity a disease, and is it actually a matter of individual responsibility? So should we just tell people that they are fat, shock them into thinking that they've got to do something, and make it their responsibility to act? Personally, I'm not so confident that that's the answer. So what I did in setting out and doing this PhD was, of course, like all good PhD students, I dived into the literature to see what it would tell me. And there is a lot of research going on in this area, particularly in primary healthcare, though more and more is going on in the community and hospital-based space. What that literature tells us is that we should follow clinical guidelines, which tend to be quite linear, things like the 5 A's framework, which I've put up here. But what the literature also tells us that even in controlled settings, people aren't implementing obesity prevention in a health services space. Now, there's practical reasons for this, time and cost, the usual things, but also it comes back to barriers that exist due to the individual perceptions around obesity and around prevention. We know that judgment is often made in relation to who might benefit from prevention and whether or not obesity prevention is actually effective in a health service space. And it is compounded by this view that preventing obesity is a matter of personal responsibility. And it was these issues relating to perception that I decided I wanted to investigate further through my research. So this was my research aim, and I'll spend a bit of time in a sec talking about what systems thinking is, but I just wanted to draw your attention to a couple of concepts in there. One, I'm only talking about hospital and community-based health services. I had to put some boundaries around my research, and I'm also only focusing on adults. I haven't touched paediatrics. And what I mean by prevention is not just primary prevention where we're trying to stop people becoming obese, but also what we might do is sometimes called secondary or tertiary prevention to reduce the negative impact of excess weight. I've framed my research within systems thinking, and it took me a little while to get my head around what systems thinking was, and I'm going to try and tell you what it is in one slide. But basically, rather than measuring something along a linear process, seeing if you do a particular set of actions, whether you get the same or a different outcome at the end, what you're really doing is exploring the relationships, boundaries and perspectives in a way to see how all those parts interconnect so that you can get an overview of the whole. Because I wanted to explore meaning, and I also wanted to base my research in a practical setting, I decided to use qualitative approach, and I got ethics approval to use Canberra Health Services and ACT Health as a case study. So I've done a series of interviews across those two organisations, and I've analysed that data using grounded theory, which is a qualitative approach, which works on the premise that rather than going into the data with a preconceived idea that you want to test, you actually allow the data itself to tell you what the answers to your problems are. So the theory is grounded in the data. So in order to get a perspective across the system, I started by talking to people at the macro level of the system. So these were people working in ACT Health and Canberra Health Services who sat at an executive level, who either had a policy, a population health, or a sort of strategic operational role. What the data told me was that there seemed to be more of an openness or a willingness to consider prevention outside of the inpatient hospital space. So I then decided to talk to clinical managers working in community health. So these were nurses or allied health staff who had responsibility for a clinical team. And then I spoke to clinicians within that team. So analysis within and across these three groups revealed two main categories, which is what I want to go on to discuss. So the first category related to the normalisation of obesity. Analysis of the data revealed that as obesity rates have increased, a normalising process has occurred, with services now more routinely providing things like bariatric equipment or modifying treatment techniques for people who are carrying excess weight. But as the population health needs have changed, with more people living with multimorbidities and more people presenting to hospital services with acute on chronic issues, inpatient services are having to discharge people back into the community with more complex needs, which means that community health services are having to manage patients with more complex needs. To cope with this change in clinical presentations, community services are tightening their service criteria in a way which prioritises treatment of that immediate reason for referral, rather than having the capacity for health promotion or prevention. At the same time, clinical services are noticing an increase in the number of patients being referred who are obese, and again they're having to adapt the way that they provide treatment. And this could be things like taking longer to do treatment sessions or sending 2 staff to attend what previously would have only required 1. However, these changes in practice aren't actually captured anywhere in the data. So there's nothing to say, for example, how many double-handed visits are as a result of the person being obese, or how many patients actually are seen in community health who are obese. So we don't actually measure how many patients that are overweight or obese. Consequently, there isn't a feedback loop between the service delivery side and policy side, meaning that there's this perception that policy response isn't actually meeting consumer needs. The clinical managers and clinicians were very clear that obesity is often a factor which impacts on how effectively people can be treated. However, it's only the community dietitians in these teams that explicitly have obesity as a reason for referral. So whilst people aren't excluded from community services for being obese, without it being an overt reason for referral or having prevention explicitly within the service criteria, there's no incentive or framework to support staff to directly address obesity or the associated risk factors. So what that means that while obesity is everybody's problem, in fact, it's nobody's responsibility. The second category relates to the way we communicate about obesity within and across the different levels of the health system, and how this influences that the health service is responding to obesity. This discourse at times saw people take quite dichotomous positions. So for example, these 2 interviewees both had the same professional background but had quite different views about whether or not obesity is a disease. There was also a dichotomy about whether or not obesity is individual responsibility. This discourse was often accompanied by a sense of futility or helplessness when discoursing the effectiveness of obesity prevention. A lot of people felt that as much as we could do in health, there wasn't really much point doing anything. There was a high level of awareness of the shame and stigma stemming from this societal discourse surrounding obesity, but a lack of confidence that health services had any capacity to make a significant impact on this stigma or on the prevalence of obesity. Now, executive staff were of the view that at an individual patient level, weight should be raised as an issue. People should be told that they're overweight and they should be weighed. But as we thought about earlier, this isn't necessarily a comfortable experience for the consumer. It's also not necessarily a comfortable experience for the clinician. Clinical managers and clinicians were very aware of the sensitivities of talking to someone about their weight and expressed concern at knowing how to raise the topic of weight, meaning that one of the biggest barriers to incorporating obesity prevention into health services is actually what should be done in terms of having a conversation about weight. People with obesity on the whole know that they are overweight. They may not understand the full impact on their health, but they will be aware of the stigma and discrimination that they face every day. Telling someone who's overweight that they're overweight won't stop them from being overweight. It won't make them lose weight, and it could actually make how they feel about themselves worse. So it's important that we continue to question this idea of having a conversation with someone about obesity. Analysis of the case study interviews demonstrated that people sitting in different parts of the health system see complexity of obesity from different perspectives. At an executive or a macro level, the key system driver is the needs of the population, and they were very cognizant of political will. Would the politicians want them to take particular actions in terms of policy? They focused on primary prevention, and those with operational responsibilities did hold the view that prevention sat outside health services, where the emphasis should be on treatment of disease. The systems drivers for clinical managers is actually their service criteria, which develop as a result of the continued focus on treatment and this continuing increase in complexity of care. But without the data, they are unable to provide feedback back to the people setting policy. And so it's very difficult for them to influence change. The core driver for clinicians is the needs of the individual, with the emphasis on building rapport and individualising care. They're very aware of the social meaning attached to weight. However, they also have limited influence over the overall systems drivers, and so are constrained in their actions by a lack of prevention policy and these quite restrictive service criteria. It's these contrasting views inherent within the obesity paradigm, along with those contested views around is obesity disease, is it a matter of individual responsibility, which may be why health services are struggling to identify the role that they should play in obesity prevention. We know that obesity is a complex problem. With complex problems come complex solutions. What systems thinking will tell us is that to achieve change within a complex system, such as health services, feedback is essential. The opportunity for change sits with bringing together divergent views from across the health system in order to challenge the perceptions that we all hold as a society about obesity, and to shift that obesity paradigm beyond a disease-focused model with a focus on individual responsibility. Enhancing feedback and bringing in all these perspectives, including that of consumers, which I haven't touched upon today, will highlight the blockages that have resulted not just from practical problems like time and money, but also from these differing perspectives. This in turn could help evolve models of care which focus on the broad range of social, biological and environmental factors which contribute to obesity, and open up the possibility of applying an approach beyond that of the traditional medical model in order to improve outcomes both at an individual and a health service level. I want to take the chance to thank my funders, the Australian Prevention Partnership Centre, who have funded my scholarship for my PhD, as well as providing practical help, and my PhD supervisors. And I'd be really pleased to hear your feedback. I'm due to submit next month, so there's still time to make some last-minute changes if you've got any brilliant ideas. Thank you.
Thank you, Claire. Are there any questions for Claire? Just wait for the microphone if there are. Diana?
Thank you, Claire. I really applaud your scholarly, the scholarly way in which you've approached this problem, because you're quite right. Just because somebody comes into hospital doesn't take away their right to refuse a set of scales, because you're quite right. I don't want to go and stand on those scales, thank
I'll
you
put
very
those
much.
away.
Yeah, if you wouldn't mind. They're triggering me. But but so when people come into hospital, you say, oh, they're obese, they're taking more resources, but they're still people. I mean, so I really enjoyed that part of your thinking and the way that you've structured the whole process. And I don't know. I'm sorry, that's just a comment rather than a question, because you've explained yourself very well. But I don't know if you wanted to explore that.
No, thank you for that. It's always nice to get that feedback. It was a difficult journey to get to that point where really I've got to accept that the conclusion of my PhD is let's just be nice to people. That doesn't feel very scholarly, but it is more complex than that. But I think if we don't begin to look at that individual experience and that societal pressure around obesity, we're not going to crack this problem. And we know people are getting sicker and sicker from the consequences of the lifestyle factors that also relate to obesity. So I think it's not the only area. I was talking to a colleague today who works in pain management, and there's some similarities there. It's about how we judge people within society. There's a lot of learnings we can get from things like sexual health, from Aboriginal health, those sorts of areas where there's a lot of assumptions made. And I guess it speaks to me as an occupational therapist to let's look at the individual, not at what our needs are as clinicians. So thanks for that feedback.
So Claire, so you mentioned that you didn't talk about the consumer perspective.
Yeah.
Is that something that you did look at within your PhD?
Originally I was going to bring in the consumer perspective, but in fact that's been done a lot, and so I can reference that in my bigger thesis. But I guess what I wanted to do, once I started talking to the clinicians, and I realised that the clinicians particularly are very, very aware of this, and they struggle with it every day. And the message that I'm trying to get back is policy isn't listening, or isn't getting that information back. And that's what I think we need to do, is open up that dialogue. Of course it needs to include the consumers, but we also need to be aware that the experience for the clinicians is also, for some of them, weight is a trigger issue, and so it's very uncomfortable for them for lots of reasons. But also they are struggling to know what to do with their patients, because it's not as simple as you tell someone what to eat and they'll go away and do it. So that's why I guess, and as you know, Ros, when you're doing a PhD, you kind of got to put some boundaries on, or my children won't speak to me ever again because I'll never finish it.
Do you have a message for the executives? I noticed that you had quite a diverse response as to whether it was a disease or not from them.
In terms of that, Hannah, I think we should just stop worrying about that. I think we almost need to come up with a third category, because there's really good arguments on both sides of whether it's a disease or not. I don't think it's the issue about whether obesity is a disease, it's our approach to the management of disease, is that we can't just approach everything in a linear medical fashion. There's a place for that, but when we think about people living outside of the health system, most of their lives are spent out there, and we need to think about them as individuals. So that would be my message. It would be, let's not forget that the individuals are at the heart of a health service.
Yeah, and we might just have one more quick question.
Yeah, thanks, Claire. I guess my question is how much do you think it's the role of an employer or a workplace? Because I think a lot of the reasons why people aren't as fit or as sort of healthy is because they just have no time.
Yeah.
And I've spent a bit of time sort of teaching in Army and Navy workplaces where, part of their job is actually to maintain a certain level of fitness.
Yep.
And there's always some sort of structured exercise or time set aside for fitness or health, if you like, during the day. So would it be something that you know, after you've spoken to all these people, would that be something that could be some sort of recommendation for employers to take the responsibility, behave a bit like defence and say, you know, we'll set aside some time for exercise?
As an ACT government employer, I need to say that yes, we do have a Healthy at Work program, which, you know, I think is getting some really good outcomes. It's always a challenge in the health space because we have shift workers, we have high demands, and as good as the intentions can be, it's very difficult. It was one of the rabbit holes that I chose not to go down with my research because it did come through as a theme, talking particularly to the clinical managers, how conflicted they feel if they have a staff member for whom weight is an issue. They didn't feel that they could raise it as a topic. In the same way that maybe 20 years ago, mental health was a taboo. We would never say to a colleague, you know, you seem to be struggling. But now I think it's become much more okay to say to someone, you seem anxious or your mood seems affected. And I think we're at the point now with obesity where it's still such a taboo topic that, yes, I agree, we should be given the space within our working week. We need to have flexible working times. We need to have flexible start and finish times if we can so that we can exercise around all other commitments. But I guess it's how do we support staff for whom obesity is an issue in the here and now? Maybe they can't do their jobs because of an injury related to their obesity. So I still don't know if I've got the solution. I guess that's the whole problem with complex problems, but it still comes back to that same thing. We need to be nice.
Yeah, and we might need to leave it there. Thank you, Claire.
Thank you.
So I'd just like to invite Melinda Choi, who is speaking about digital health tools and vulnerable populations.
Okay, thanks. My name's Melinda Choi. I'm a GP in Gordon, just down south, and I also work as a lecturer within the academic unit of general practice at the Australian National University. So I'm talking about digital health tools and the therapeutic relationship can each help a vulnerable population in general practice. So my research was funded by the Royal Australian College of General Practitioners, and it took place at the Arterial Wellness Centre, which is around the corner at Directions in Woden. So, digital health. We do our banking online, we do our shopping online, and we have stuff like My Health Record now too. The World Health Organization defines digital health as a use of information and communication technology for health purposes. It's pretty broad, so what I'm interested in is patient-initiated digital health. So that can include things like booking an appointment online, or using a health-related website, Googling health information, or even using an app on your phone for stuff like sleep, exercise, pregnancy tracking, mental health. eHealth promises us that it will make our health services more efficient, it'll improve outcomes, and it'll make our patients happier, more engaged, and more empowered. Sounds great. Obviously, lots of questions, but my question is about how vulnerable populations engage with digital health. Are those who are socially and economically disadvantaged going to be left further behind as a result of increasing reliance on online health? Or could some of these tools and technologies decrease outcome gaps? A key question to understanding that is what is actually the experience of the vulnerable patient of digital health? Within that, I'm interested in subpopulation of patients with substance dependence. We know that patients with substance dependence are more likely to experience social and economic disadvantage. We know that they also have high healthcare needs, both related to substance dependence, but also a whole range of comorbidities. So I think if we're looking at digital health, it's important to see how these people specifically experience it. I'm also, in this project, was a bit interested in the therapeutic relationship and how digital health impacts that. Does introducing something like this make it more artificial, or does it actually improve the relationship because the doctor has more information about what's going on? So that's where this digital health tool comes in, the electronic case finding and help assessment tool. It's designed in New Zealand, primarily for use in general practice. What happens is you've got your patient sitting there in the waiting room about to see their GP, and they fill out these multiple choice questions, answering questions about screening questions about drug and alcohol use, mood, and physical activity. That information then goes with that patient ID on a separate server to the doctor, who reads that kind of at the same time you'd read the patient notes at point of care just before picking the patient up from the waiting room. So it's had good feasibility and acceptability studies, but this was the first trial in Australia and the first trial in a specifically vulnerable population. So to bring it all together, essentially I was looking at the Arterial Wellness Centre and how patients experience this eChat tool. In terms of methods, I took a qualitative approach, mostly did interviews with patients and doctors at the clinic, and also ran a focus group with the local community advisory group. Did qualitative data analysis, thematic, with 2 coders, and then a variety of coding meetings with our team. We ended up with 12 patient interviews, 2 doctor interviews, and 1 focus group, the community advisory group attached to the clinic. There are 5 themes. The first theme was actually really interesting and a surprise to a lot of us. It's this idea that eChat could reduce stigma and help patients tell their story. We had a sociologist on our team, and he talked about this idea of performance of illness, this idea that when a patient is in front of you, they have to communicate what's going on with them. And patients seem to reflect that eChat helped them do that. The patient quoted here talks about how he's actually able to be more honest about his drug use in a way that he wouldn't have been, and potentially get help earlier. Other ways that patients felt that it improved their performance of illness was that it helped them be more honest with themselves, or even just in the waiting room, helped them order their thoughts about what they were going to say to their doctor. And some of them just said it helped start the conversation. So I thought this is a really interesting thing, particularly in the light of our population, this idea of potential reduction of stigma. In somewhat contrast, we noticed as well that eChat, a lot of patients had trouble with the idea that there were the restricted answer options. So because it's a screening survey, there are multiple choice questions, but a lot of them commented on that lack of free text. They mostly commented on this around the questions related to drug use and stuff like frequency. They're like, I don't want to say that I use based on days, weeks, or months. I need to explain that it's emotional breakdown or payday or something like that. And the person quoted here, she found it so frustrating that she couldn't give a true story, that she thought the whole thing was pointless. We also came across the idea that patients, where they were at, impacted how they responded. So things like their own things like, so the glasses are there, some people had trouble reading it. The doctors reflected that patients who come in early with acute urgent agendas, consuming the whole consultation, eChat wasn't very useful for them, but later on down the track, it became quite useful. Efficiency is a really common theme across this trial and also in New Zealand. Patients like being able to give their doctors more information in that waiting room time. The final theme is this idea of consent, security, and privacy. We did this during the My Health Record rollout. So there's a lot of debate in the media about security and privacy, and yet the patients that I interviewed were very unconcerned, very unaware of security risk, whereas in contrast, a focus group who are patient advocates, not about to see their doctor, interviewed kind of in a group setting, were much more kind of empowered and worried about security risk. Quick note about the therapeutic relationship. Of note, whether the patients felt positively or negatively about eChat did not really change how they felt about their doctors, particularly in a negative way. Some of them felt more positively than new patients. So I think that was a useful thing, but probably we didn't really have the numbers to look at that properly. Ultimately, one good thing to come out of this was that the idea that eChat has the potential to help patients with substance dependence in general practice engage more honestly, completely, and efficiently with their doctors. We thought that looking at the other themes, if eChat was going to be implemented in this setting, it does need to be combined as a complement and not a substitute to the in-person consult to allow for the issues of restricted answers, and it works best as an optional process with very clear informed consent process to cover that security, privacy concern issue. Personally for me, I found that doing this project helped me see that specific research into the vulnerable patient experience is essential to ensure that when we implement these
e-health wonder solutions, that they actually help everyone. Thanks.
Thank you, Melinda. That was really fascinating. Do we have any questions for Melinda? And if you do have a question, can you try and keep it snappy, please?
Thank you, Melinda. I was really interested in your comment about the patients feeling they could be more honest without that doctor's gaze upon them.
Exactly.
And it just it made me think about adolescents. When you want to talk to an adolescent, you don't look at them. You get in the car so they're next to you, and they're much more communicative. It must be a human thing, do you think?
Yeah, so I think it's that idea. Even though they knew that the information was going to the doctor, when they were just answering the screen, it was much easier. And that comment that you made about the adolescents is really interesting, because eChat in New Zealand, it started as eChat, and then they got Map Chat, Youth Chat, but the thing that's taken off the most for them is Youth Chat. So they're using that in schools, and they're finding that a really useful way to screen adolescents. Yeah.
Any other quick questions? Thank you, Melinda.
Thanks.
Angelos? Yep, do you want to come up to that? So our next presenter is Angela Sharabeam, who is talking about anticoagulant prescribing practices in patients with ischemic stroke and how that's changed over a decade.
Hey, thanks everyone for coming. Thank you to conveners for the opportunity to present our research today. So today I'll be presenting our research which we performed in the stroke unit this year about anticoagulant prescribing practices in patients with ischemic stroke, and comparing it to research which we've done 10 years ago now. And what we wanted to see was what's changed, what's stayed the same, and what lessons we can learn from these studies. So just by way of introduction, ischemic stroke is a well-known leading cause of morbidity and mortality worldwide, and atrial fibrillation, or AF, is a major cause and contributor to ischemic stroke and subsequent morbidity and mortality. The role of anticoagulation is fairly well established. There have been large international studies which have shown certainly it's superior to a lot of other medications, including Warfarin for atrial fibrillation. However, despite this good evidence that we already have in place, there's also evidence that shows anticoagulation is underutilised despite patients being eligible for its use with ischemic stroke. So the previous study which we performed at TCH revealed that there was evidence of under-anticoagulation 10 years ago. Of the patients who came in who were under or not anticoagulated, certainly a significant proportion of those strokes were associated with under-treatment, which I will go into in a little bit of detail. Since then, however, we've moved over from essentially being most patients on Warfarin back in 2009 to patients now being on direct oral anticoagulant therapy with a number of different agents. So we have shifted a little bit in terms of what medications we've used, but how is that translated into the numbers that we've actually got? So what we wanted to see was we wanted to look at the prevalence of atrial fibrillation in our stroke unit population, the extent of anticoagulation for AF prior to admission, at the time of discharge, compare those on Warfarin to those on a DOAC, and also compare these results to our previous study in 2009. So over a 2-year period, all the patients who were admitted to our stroke unit with a discharge diagnosis of ischemic stroke or transient ischemic attack, or TIA, were included. However, if they had a primary intracerebral bleed or a clear non-stroke diagnosis or inadequate documentation, we excluded them from this particular study. A number of demographic data points were collected. I'll just draw your attention to anticoagulant type and dose, so that can specifically include medications which we've seen, so Warfarin, dabigatran, apixaban and rivaroxaban, as well as clexane were the 5 that were seen in this particular study. And the contraindications could vary, but particularly on admission, they included things like patients having a bleed, patients in the previous study have multiple falls, alcoholism, dementia, patients being palliated, for example, amongst others. So in this particular study, we looked at patients specifically with ischemic stroke or transient ischemic attack. There were a number of patients who also had hemorrhage, but we decided to focus on those with ischemic stroke and atrial fibrillation in this study. So despite the number of patients increasing from 391 to over 600 in 2019 over a 2-year period, the proportion of patients, or the prevalence rather, with atrial fibrillation has actually not changed significantly. And this is also borne out in a number of international studies as well. So it's just around about a quarter or just over a quarter of patients who have atrial fibrillation. So it's a very busy slide, but of those patients who have ischemic stroke and known atrial fibrillation, the number who were anticoagulated on admission has not changed significantly over the years. However, quite pleasingly, those who were appropriately anticoagulated had improved significantly. Now, what's one of the potential reasons for this? All the patients in the previous study were on warfarin, and now a proportion of those who were previously on warfarin were now on DOACs, because DOACs essentially were not available in 2000 in the previous study. So there's been a commensurate decrease certainly in warfarin utilisation in that time period, but also a reduction in the number of patients with subtherapeutic INR. Those on oral anticoagulants, however, unfortunately there was still a number of them who were still being underdosed despite being on a tablet, which theoretically should be easier to take, easier to dose, easier to monitor without the need for regular blood tests. On discharge, there were less patients who had overall contraindications to anticoagulation, and the number of patients who were anticoagulated on discharge overall did change slightly, and this is perhaps also an issue with essentially possibly discharge documentation, or could actually glean from the notes in terms of documentation why patients were or were not on anticoagulation. However, those who were anticoagulated, there was 86% versus 96% were appropriate anticoagulated. So there certainly has been an improvement in the number of patients appropriately anticoagulated over the 2 study time periods. Just looking a little bit further in terms of a breakdown between warfarin and oral anticoagulants. Certainly whilst there's been a reduction of the number of patients on discharge who are taking warfarin, and a significant number of patients now on the oral anticoagulants, there's also been quite a large number of patients who are now, so essentially on an appropriate dose as well, so 77 out of 82, which is quite pleasing as well to see. So the majority of patients were being dosed on an appropriate dose of oral anticoagulant, and that is based on a number of factors according to manufacturer's instructions, including age, renal function, and weight. So what does all this mean, taking all this into consideration? Whilst there was no significant difference in AF prevalence between the 2 studies, there were a significantly higher proportion of patients appropriately anticoagulated on admission. However, there was still a large proportion of patients who were either not anticoagulated or under-anticoagulated on admission. And certainly whilst this may certainly be due to factors which we do not know about, because we didn't survey or go into call up all the GPs or specialists who may potentially prescribe this anticoagulation, there was still quite a large number there who were under-anticoagulated. And interestingly enough, despite having the same number of AF patients overall in terms of prevalence, there were a high proportion of strokes on anticoagulation in the current study, which may almost raise the question, how effective is this anticoagulation that we're using at the moment, given that majority of the patients are actually on oral anticoagulants versus warfarin, and yet we're having a high proportion of strokes coming in on anticoagulation. So it does raise a question about that. There are few patients with contraindications to anticoagulation. 12% were not anticoagulated on discharge, and under anticoagulation is still present, but all in the oral anticoagulant group, interestingly enough. However, those who were appropriately anticoagulated were more consistently done so in the DOAC group rather than the warfarin group, perhaps due to ease of monitoring as well as patient preference. So there are a number of limitations to this study, including the sample size. We're obviously seeing a bit of a referral bias in terms of we're seeing the patients who are coming with strokes and anticoagulation, so either a failure of anticoagulation or being under-anticoagulated, a single centre, the retrospective nature of the actual study, and also potential confounders, including ischemic heart disease, heart failure, and a number of risk factors which may have also played into the results as well. So whilst there's been an overall increase in the use of anticoagulants, anticoagulation is unfortunately still underutilised in many patients with AF, particularly on admission. And those anticoagulant on discharge did form a significant higher proportion than those on admission in both studies. However, there's still certainly scope for us to improve both on admission and on discharge the number of patients who are anticoagulated, perhaps through better community resources and education.
Thank you. We have, I think, time for one question. Yeah, if you could just wait for the microphone. Just so the world can hear us on the live stream.
Thank you so much for your presentation. I was really interested in, so you were talking about people presenting with stroke who also had atrial fibrillation. Is there any, are you able to access information, or do you know the information about people coming into hospital with atrial fibrillation and the proportions of them who are anticoagulated?
For other reasons?
For other reasons, yeah.
We didn't look into that specifically. So we just looked at those who came into our stroke unit essentially with strokes. We didn't specifically look at those that, who are on anticoagulation for other reasons in this particular study, but it certainly is an interesting question to sort of have a global picture of that.
Thank you.
Thank you. And if I could just comment on that, one of the problems that we don't have is the denominator of how many people are being anticoagulated. People hated Warfarin, so they didn't use it, whereas everybody tends to think, and I think find, that the DOACs are much easier to use. So allowing for our it's difficult to interpret these unless we have some idea of the proportion of the population that's actually using those in the first place. So we're going to try to look to see if we can get that sort of information, but I think it may prove a little bit harder than we would like.
Thank you very much.
Thank you.
I'd like to invite our next speaker, Sumit Rai, who is presenting about characteristic and outcome of very elderly patients admitted to Australian and New Zealand ICUs. So this is a bit of an Australasian study, I think.
Thank you very much for allowing us to present the data at CHAM. As you can imagine, we've looked at the very elderly patients as defined as anyone 80 or over the 80 years of age who were admitted to Australian and New Zealand intensive care units. And it's a retrospective study. You can imagine a study of that scale cannot be conducted without some significant national and international collaborators. So I'd like to acknowledge that and thank them for that. So what's the background? Why did we do this study? Well, the Australian Bureau of Statistics projects a 100% rise in the octogenarian population in Australia in the next 13, 14 years, by 2032. In addition, there's variability in literature and admission trends and mortality of the very elderly or the greater than 80 years of age patient population admitted to intensive care. There's some Australian data on that. An older study by Sean Backshaw's group showed that there's a 5.6% per annum increase in ICU admission rate for the very elderly cohort, compared to a later study, regional studies with Victoria and other studies, which showed probably that this is now slowing down. In addition, due to the complex medical and social and surgical problems and comorbidities of the very elderly patient population, the mortality rates projected in literature is very high. So European studies have showed mortalities in excess of 30%. We're probably slightly better in Australasia. In Australia and New Zealand, between 2000 and 2005, our mortality rates were around the 20 to 25%. Even despite that, the adjusted mortality rates were rising in this earlier ANZ ICU study. The Victorian study, which is slightly, looks at that time period, but also extends it out, looks like it's starting to come down, but even then we're sitting at around the 20-25% mortality mark. So that's 1 in 4 of your very elderly people dying as an outcome after their intensive care admissions. So we wanted to look at, characterize this and look at the trends, especially because we were concerned with the earlier study of Sean Bagshaw's group, which was an ANZ study which actually showed and projected a 72% increase in ICU admissions for the very elderly or the over 80 population by 2015. I wanted to see where actually that was true from a population planning point of view, for a health planning point of view. We want to see this trend. We wanted to look at the outcomes for the critically ill, very elderly patients and compare that to the younger cohort. So we looked at a number of outcome measures. The primary outcome we kept as hospital mortality because that was easily and readily available through the database that I'll briefly talk about. The secondary outcomes we looked at were intensive care unit mortality, and we did look at some resource utilization. Now, this was limited to what we had in the database. So we looked at ICU and hospital length of stay, looked at discharge destination to chronic care and rehabilitation facilities. We used de-identified data from the Australian New Zealand Intensive Care Society adult patient database for a period of 11 years, looking at all adult ICU admissions. This database is one of the largest single intensive care unit patient databases with over 2 million patient episodes from over 183 intensive care units. We extracted this de-identified data, looking at a number of things with these inclusion and exclusion criteria. We excluded out patients who were less than 16, those who had repeat ICU admissions, or those who were transferred to another ICU because we couldn't get their outcomes out. There was only going to be one outcome for multiple admissions. Or those who had admissions for palliative care and organ donation were excluded out. So this de-identified data included source of admission. It included their physiological and laboratory variables for the first 24 hours, which we used to calculate for the severity of illness scores. It looked at comorbidities. It looked at what intervention was available in ICU for the first 24 hours. It looked at their length of stay. It looked at their discharge destinations and mortality outcomes. We also extracted the Australian and New Zealand risk of death model for every patient. This is a model which has been benchmarked for ICU outcomes in Australia and New Zealand by the Australian New Zealand Intensive Care Society. It's been well published and looks at a number of parameters from a severity of illness point of view. And only a few of those look at chronic health problems or age, because that was, we thought, going to be a significant problem with this patient population. So only around 20% of the weightage is to that aspect. But there are a number of additional things that this model gives us, which the other severity of illness doesn't give. It gives us treatment limitations as well, whether they were in place or not. So what did we find? We assessed 1.3 million records through the Australian New Zealand ICU database. After excluding out non-eligible patients, we analyzed 1.24 million data sets. The over 80 accounted for 185,000 patients, which is around 14.9% of the whole study cohort, for 1.24 million patients. The very elderly, or the over 80 years, mean age was 84.8. Most of them, 90% of them, came from home or other acute care facility. 2.4% did come from chronic care facility. They obviously had higher comorbidities, which we did expect. From their ICU admission source point of view, most of them came to us either through the operating theatre or through the wards. Less of them came through emergencies. There was no difference in elective surgical admission rates, though, between the two groups, between the younger cohort and the elderly cohort. So a lot of our patients were medical, with a variety of admission groups, GI and cardiac being the more predominant one in the very elderly. So we looked at the severity of illness through a number of parameters. Apache is an acute physiology chronic health evaluation, and the ANSROD model that I've spoken about. In all of these models, the severity of illness was higher in the very elderly. Now, because Apache has an age component, we excluded out the age component and looked at it again, and yet Apache's, the severity of illness was still higher in the very elderly population. And the risk of death were much higher with any of our models that we have. Looking at the trends, though, over the years, there's been a steady increase in the admission rates for actually both cohorts. Both cohorts demonstrated approximately 45-46% cumulative rise in their admission rate between the 11-year study period. But that trend was actually much slower for the very elderly compared to the younger cohort. The very elderly cohort only had a 0.7% increase between the end and the beginning of that. What about outcomes? Hospital mortality was twice of that in the very elderly. ICU mortality was also higher. The annual mortality trends, though, kept going down, and we know that from other databases and publications from the ANZ ICUs that mortality trend has been coming down for all age cohorts. But for the very elderly, over 80, that trend was much steeper. So that was a decrease in 0.8% compared to a 0.3% decrease in mortality trend for the younger cohort. And even adjusted mortality trends were much better and getting much better for the elderly patient population. From a resource utilization point of view, hospital length of stay was much higher for the very elderly, despite having a low length of ICU stay. And their ICU bed days was actually not that bad. The rise was only 145 bed days per year compared to 1,045 bed days for the younger cohort. And from a resource utilization point of view, only 55% of the very elderly were discharged home. 16.5% were discharged to chronic care. 90% of these came from home or another acute hospital. They did not come in from chronic care. So majority of these patients who were going to chronic care were all new. The discharge to chronic care trend was rising, much steeper for the very elderly, and even adjusted trends were rising. So STRENGTHS is a large database, it's a large study, but there is a selection bias because we did not have data on refusal of ICU admissions. We did not have data on a number of important factors because of the limitations of the database. We did not know their pre-existing frailty. That wasn't being collected till 2017. We did not have valuable outcomes that we would have liked to see in one-year outcomes or health-related quality of life or functional status outcomes, unfortunately. But we think, to conclude, there's been a steady increase in the number of ICU admissions in the very elderly cohort. This matches the admissions in the younger cohort. The proportion remains the same for the very elderly, hasn't changed over the years. The very elderly were sicker, higher comorbid burden, but they also consumed more resources and they were more likely to be discharged to a chronic care facility. Thank you very much.
So unless anyone has a burning question, we probably don't have time. We might move on to Drew Richardson, who is talking about access block and critical boarding for mental health presentations.
Thank you, and thank you all for staying till the end of a long day. Those of you who were here last year will recall that I presented a paper on the incidence of access block in mental health presentations in Australasia. It was the first paper of its kind, a binational survey of Australian and New Zealand emergency departments, and it showed quite dramatic differences in the incidence of access block for mental health patients. As you can see there, the difference between Australia, adolescents, and New Zealand are the first two columns, and it was really quite stark. The fact that mental health patients spend longer in the ED suggested to the authors that there was some discrimination against this group of patients, be it systemic or individual, that they are staying longer where other patients aren't. Now, there's a theoretical weakness in that. We don't believe that the theoretical weakness is relevant, but it certainly is a weakness. There's no doubt that the assessment of a 25-year-old with a new psychosis is going to take longer than the assessment of a 25-year-old with a new fractured ankle. It shouldn't really be taking more than 8 hours, but that certainly is a confounder. So we addressed this with a second study. This time we looked at access block, which is universally defined as 8 hours in the ED and needing admission, and also 24-hour stays in the ED, using the American term boarding here, meaning patients who need admission and have finished their emergency care but are remaining as boarders in ED. You can argue about whether a long assessment might drag things out to 8 hours, but 24 hours is unacceptable in any context. So this was a binational voluntary survey of all 140 adult and mixed emergency departments accredited by the Australasian College for Emergency Medicine. The EDs who participated reported data for 7 days from 31st of October last year. The methodology was identical to that of the POMAB study I presented last year, but deliberately done at a quieter time of year in school holidays where there should not be as much demand, and with the addition of a stay of 24 hours question. Definitions: mental health presentations were defined as those with a clinical need for review by a mental health clinician during their ED stay, meaning overdoses who went to ICU were not relevant. It was those who received mental health care in the ED. Admissions were defined as inpatient wards and not ED short stay units. The age cutoff we used for adolescents was 18, logically enough. And access block, the standard definition of a total ED time of 24 hours, and what we called critical boarding, 8 hours for access block, and critical boarding was 24 hours. 50 EDs, 35% answered. Given the resource implications of collecting a whole week of data, we're pretty pleased with that result. And we then had a database of 52,000 presentations and over 12,000 admissions. This is definitely the largest database of its kind looking at this work. There were 2,699 mental health presentations, about 5% of presentations within that group, and that matches what's in the previous literature, and 711 of them required admission, so an admission rate that's pretty similar to that of other patients. In the 8,112 adolescents, access block rates were 88.2% in patients who didn't have mental health presentations and 41.7% in those patients who did have a mental health presentation. Pleasingly, however, adolescents basically never stayed 24 hours in the ED. There was one case in the whole database. In adults, 33% access block if you didn't have a mental health presentation and 42% access block if you did. Highly significant difference. And the 24-hour stays, a staggering difference. 1.8% if you did not have a mental health presentation and 8.4% with a mental health presentation. When we break it down by jurisdictions, the four columns for each group here are pediatric or adolescent non-mental health, pediatric mental health, adult non-mental health, and adult mental health. You can see, to look at the first one, out of 45 hospitals in Australia, there was a significant difference in access block for both the pediatric and the adult group. It was not evenly distributed. There were major issues in New South Wales, and it looks like significant issues in the smaller jurisdictions, the rest at the far right-hand side of the graph. There was no significant problem in New Zealand. In Australia, the odds ratio for adult access block in mental health cases was 1.5, which was significant. In New Zealand, it was not significant. For critical boarding for 24-hour stays, the odds ratio in Australia was a massive 4.7, and there was no critical boarding, no 24-hour stays at all in New Zealand, and none in Victoria. That's a very dramatic difference, and frankly, an appalling intrusion on these people's human rights and their right to a reasonable standard of health care. So ED patients with mental health presentations do have a similar admission rate to other groups. They're disproportionately likely to experience access block. We already knew that in adult and mixed Australian EDs, and much more likely to experience critical boarding of more than 24 hours. This is very strong evidence of discrimination in the bed management process, rather than any effect of patient complexity and difficulty of assessment. Of course, this is a voluntary survey. It's inevitable that people with a problem might be more likely to report. It's reliant on local interpretations of definition. We've got no way to go back and audit it. In conclusion, ED patients with mental health presentations are disproportionately likely to experience access block in adult and mixed Australian EDs, and much more likely to stay more than 24 hours. This is strong evidence of discrimination at a systemic level in the bed management process. And the Victorian and New Zealand experiences clearly show that it does not have to be this way. I'll take any questions if I've got time.
Thank you, Drew. Definitely time for questions.
Thank you, Drew. Thank you for your presentation. Fantastic as always. You're saying this is unequivocal evidence of discrimination, or is it evidence that you've got mental health patients coming into your ED because we don't have other systems for it, and there's a block at the other end because our mental health beds are full?
Well, if our mental health beds are full, we're discriminating by not having sufficient mental health beds. Discrimination here is systemic. I'm not picking on individuals or saying it's an individual bed manager or something like that. I'm saying that the system is quite deliberately not set up to give these people the same flow through the ED that those without mental health presentations have, and the responsibility for that rests with our managers and how we distribute the healthcare dollar.
Yeah, well, I don't disagree with that, but is that the acute hospitals? For instance, does New Zealand have a system whereby they can filter their mental health patients in the community more effectively than we do?
New Zealand has actually slightly less mental health care beds than we do. So it's not about bed numbers.
No, well, I guess that's what I mean. Have they got better support in the community? I don't know.
New Zealand also doesn't have significant 24-hour stays in non-mental health patients.
Thank you. Drew, I'm sure you can't, excellent presentation. I'm sure you can't speak to this, but I just wonder whether you had any thoughts. One of the problems with access block is not so much getting from the ED to the next specialty, but for that specialty to get rid of its patients down to the next stage. So, for example, in neurology, trying to get people to nursing homes and that sort of thing.
Indeed.
And I just wonder whether, presumably, the mental health people have a similar sort of problem, and is that the institution's failure? How do you interpret that?
They do have some problems like that. Whether that's the institution or the healthcare system is an arguable point. ICU in our hospital certainly has problems getting patients out to the ward. They suffer exit block the same way we suffer access block to get in. And this is about how the healthcare dollar is distributed. We cannot, in fact, do everything. There's rationing at every point in the healthcare dollar. I've long argued that rationing by queuing stops making sense when the time course of the disease is similar to the length of the queue. And that's absolutely the case for people with brief mental health disturbances who spend 24 or 48 hours in the ED when you're expecting them to stay only 2 or 3 days in the mental health unit, because they don't get better in the ED. It's not the appropriate environment, as it is not for stroke patients either, once their acute care is finished. And it really concerns me that this particular vulnerable group of patients seem to be suffering more than others from the dysfunctions we have in our health system.
Well, thank you, Drew, and I'd like everyone to just thank all the presentations for this afternoon. They're all really interesting.